Alkaptonuria is a disease that's often diagnosed at birth. I mean, parents recognize the nappies of children turning dark, but it's just, it isn't doing anything beyond just being a nuisance at that age. So parents and the doctors caring for these children often just recognize it, and patients are lost to the system because they just become adults and they have problems much later on in life. And there is a lot of issues for alkaptonuria, which also applies to other rare diseases. And once patients are lost to the system, because it is so rare, 1 in 250,000 to 1 in a million, patients are totally isolated in wherever they live. The doctors have never heard of the condition, and they are totally isolated and dispersed. So this is firstly a huge problem, how we bring them together, how we support them. So they also, because they're lost to the system, they think that alkaptonuria is a benign disease, which it has been for several decades initially. But of course, this is a condition which becomes more morbid as you age, after the age of 30 and 40, and patients don't necessarily realize that they're getting ill at that point because they can't see their joints, which is a major target. Because of all that, the pediatricians generally think that this is a chemical curiosity, and adults, of course, are not targeted for care, they're not targeted for follow-up, they're not targeted for genetic, for conditioning, for dietetic and lifestyle counseling. So for all those reasons, it is important to provide something in the system that's going to help young people as well. As I've already said, there's a lack of local knowledge and expertise, and of course, so far we have not had any treatments at all, but thanks to the potential for nitisinone to become a treatment, we can provide access. But again, anybody who's worked in the NHS will know that it's a lottery fighting for expensive treatments, negotiating with the local health systems, and believe me, I have tried to do that for several of the patients living in Liverpool with little success. So nitisinone is not the most expensive drug, but nevertheless, there is an expense around that, and therefore we need a simple mechanism to help our patients. We need to do all this so that they have a better quality of life in adulthood. So these are patients who become really in danger at the peak of adulthood. They have all sorts of health problems. So we need to look out for them. And of course, as always, nitisinone is available at the present time in terms of a good proof of concept and the fact that it works in bringing down homogenic acid, but we still need outcome data. But there are also issues, as you already heard from Wendy intro, about the tyrosine and the other issues, so we still need active research programs to try and develop new treatments as well. So I'm just going to sort of paint the scenario in Britain. So when I got interested, I'm a busy physician, by the way. I run 2 metabolic bone clinics. I run a cardiovascular lipid intervention clinic. I've got I also have a dual role working in the lab and working in the wards. So I'm quite a busy physician. So I got interested in alkaptonuria purely by chance because I met the founder of our society in 2003. So he turned up with his niece who thought she had AKU like her uncle, and I got interested in that, in this condition. At the time, we only knew of 2 people in Liverpool with this condition and 2 people in Cambridge through Nick Ciro. So this is all we knew of when we started. We didn't know how many patients there were in the UK. And if it is anything like the rest of the world, it's about 1 in 250,000 to 1 in a million. So the first thing we wanted to do was we wanted to identify as many people as possible with alkaptonuria in the UK. So this was the first thing we wanted to do. So to do that, we were lucky to get funding from the National Lottery. We got about £220,000 given to us. We are really grateful to them for that. And through that, we established the Alkaptonuria Information Centre in my department. And in turn, we were able to employ 2 people full-time to try and identify people with alkaptonuria in the UK. And we did this in a variety of ways. We surveyed GPs. These 2 full-time people in the Alkaptonuria Information Centre attended conferences, so that we could ask people attending the conference whether they had patients with AKU, and we also targeted the family once we identified a patient, because that's one of the best and easiest and cheapest ways to do that. And of course, we had the full-time manned website as well. So all of these strategies, we were quite lucky in the sense that we surveyed 16,000 GPs in the UK, and through that, with the UK population of 60 million, we now know of more than 80 people with Alkaptonuria in the UK. Clearly, if you are going to do anything for a patient group, or a group of patients, then you need sufficient numbers to undertake any programs. So we did that right at the very start. Purely by chance, people attending the conferences were also able to tell these two full-time people in the Alkaptonuria Information Centre about the number of patients in the rest of the world. So if you really think about the world population of 7 billion, then if it is 1 in a million, there should be 7,000 people with AKU, and if it is 1 in 250,000, there should be at least 28,000 people around the world. But that is probably an underestimate, as we know, in parts of the world where consanguinity is higher and all the other issues are. But nevertheless, in Europe, we know of more than 450 patients, which is quite important because we're just about thinking in terms of embarking on some clinical studies in Europe. And worldwide, we are now aware of more than 1,000 people with this condition. So doing the patient information study has been really helpful. So having had the patients, we're wondering, what do we do next with these patients? So we now know that they're there. So we thought, let's invite a group of patients to come to Liverpool. Let's systematically investigate them. Let's see how healthy these guys are. And so this was the next thing that we did. So we did this between 2008 and 2010. And this was supported by a small grant, £60,000 by the Childwick Trust. And we brought 16 patients, 1 patient from Germany as well, for 3 days and 2 nights for a metabolic ward in the Royal Liverpool University Hospital for a full comprehensive assessment. And the sort of assessments that they had, they filled in 9 detailed questionnaires. They had clinical assessments, usual physical examination, history taking. They had physiotherapy and dietetic input. They had a scintigraphic scan of the joints, whole body MR and joint MR. And they had ultrasound of the abdomen, echocardiogram, ECG, X-rays of the spine, and other metabolic studies. And so this is what we did. The reason for pointing this out is this is a sort of forerunner of the kind of things we want to do in the FP7 project that we're doing. So I'm telling you where this approach has come from. So this is what we did. So having done that, there again we were at a loose end. We said, okay, we've done the clinical evaluation study, now what? So we got all these patients dispersed around the UK. How do we manage them? So we came up with the idea that we probably needed a centre where we needed to do more than just assess once and leave them alone. We wanted to bring people back and, if possible, intervene in terms of need-to-know diet and other things. So this was the ethos behind trying to set up a centre for Alkaptonuria. So the idea was to bring people once a year, get them access to the kind of things we did in the clinical evaluation study, access to a multidisciplinary team, and we want to do a systematic assessment by this team. And we have a fantastic group of researchers at the University of Liverpool with Professor Jim Gallagher and John Jarvis, who's chairing this, helping us along. So we are a very active research team. So we need the clinical material there to support this research. Because nitisinone was also now available as a potential treatment, we thought it was a very good time to embark on trying to create a centre. We were again extremely lucky. I mean, just in March 2011, Department of Health called for a rare disease call. They said there's, apologies for the spelling, that's a CENTRES. So you can see I've been working late at night. And so this rare disease call came up in March 2011. We submitted the stage 1 application in May 2011. We were shortlisted, but we were selected for that. And then in September 2011, we sent the stage 2 application for that. And in March 2012, we got the green light. The Department of Health said, okay, now the National Centre for Alkaptonuria, and so there's no April Fool's Day. I'm not sure whether you know of what April Fool's Day is, so we thought it might be April Fool's Day, but it was actually real. So from the 1st of April, Royal Liverpool University Hospital was a designated national centre for Alkaptonuria. We were operational in 2012 because it still takes time to get people together, to have all the structures and the procedures and other things in place. So our first patients arrived in the centre in June 2012. So the role of the National Centre is, I'm just going to confirm for you in this slide. So the National Centre is open to anybody who's 16 years of age or over, because we are an adult hospital. Okay, but we've already had discussions about diclofenac and in relation to tyrosine. So we will need to think about how we do that carefully. But at the moment, we do have some young patients in the National Centre who are attending. But potentially it is open to anybody over the age of 16 in England and Scotland. Wales and Northern Ireland are excluded because they're a different country, different health systems, different agreements with the Department of Health in the UK. So again, the model is going to be like what we did before. We're going to have a National Alkaptonuria Centre based on a ward in the Royal Liverpool University Hospital. It's a 4-day inpatient assessment. So this is how it works. So we have the service in Liverpool. We are answerable to the Department of Health in London. And of course, we liaise very closely with the AK Society, who are linchpin for us. And of course, we are communicating with something called Patients Know Best, which is a web-based system directly with the AK Society, with patients and with the local doctors. So we're doing that at the moment. So this is the model that we're following. And the way this also works is GPs refer patients to us, and patients come to the Royal Liverpool Hospital. We do a clinical examination and identify the problems. Then we do assessments so that we can follow an outcome in a systematic way. And if they have any active problems, we try and resolve those as well. That's specific to that patient. And then once the treatment is done, patient return to the local locality where they came from, and we try and manage any treatment needs for them in the locality, and they're discharged and they follow up and return a year later. So that's the kind of model that we follow in the National Centre. This sort of gives you a sense of how much more we are doing in the National Centre compared to the clinical evaluation program we did. So the assessments are cardiology, rheumatology, ophthalmology, ENT, orthopedic, dermatology, spinal dietetics. So each of the consultants turn up to the ward over the 4-day period, which is a very, very busy time for our patients. They quite struggle to keep up with all the activities. Providing them with food and drink properly is quite a challenge because people are all over the place, but this is what we do. Besides that, they also have medical photographs taken in the medical illustration department, and they have a lot of investigation, as you can see, PET-CT, MR scan, genital ultrasound, ECG, echocardiogram, metabolic studies, and an ear biopsy as well. Because the most direct way of seeing if somebody's got achondrosis is take tissue sample, so we're doing that. And in addition to nitisinone, we also engage a physiotherapy department with patients so that they can identify if anybody needs a bit more physiotherapy needs, and we try and coordinate that with the locality where patients come from. Every patient in the centre receives advice from a dietitian about a low-protein diet. But the problem we have is we don't know what a low-protein diet is in Alkaptonuria. I think pediatricians are very hot on low-protein diets. They want to go low. So but I've had letters from London, from the pediatric department, saying that why are you giving 0.8 grams per kilogram body weight of protein? Why not going low where you should be giving 0.4? On the other hand, I get Professor Timcock from Cambridge, who's an adult metabolic physician, saying, why are you giving so low? You should be giving a gram a day. So I guess I'm saying in adult AKU patients, we don't know what a low-protein diet really is, and we're going to try and find out a little bit more in terms of data. So we've called our centre after our founder. This is Mr. Robert Gregory, who I was privileged to meet all those many years ago in 2003. Robert was a big, hefty man, 6'3", 6'4" when I first met him. And unfortunately, he's now quite severely disabled. He's in a wheelchair. He can hardly move. So we have named our center after the founder of this of the society. And in order to support all the activities, we need really good liaison and support from the patient society, and we are really, really lucky to have that through Dr. Nick Siro, who is the chair of the AK Society. I'm part of the AK Society, so I've got several hats. I'm part of the AK Society. I'm a medical director and a co-founder of that, but Nick has been leading the AK Society for a number of years very successfully, and everything we have done we would not have happened without him being part of everything we have done. And the AK Society has appointed Leslie Harrison, who's in the audience somewhere. Where are you, Leslie? There you are. Who is a linchpin really for our service. She accompanies patients to Liverpool. Well, she's there in Liverpool to be with patients who arrive there. And even before they come, she helps with the logistics, gives them information about how and what is going to happen in the center. And then the AK Society helps patients with travel, costs, and everything else. And they are really, really crucial in terms of publicizing the existence of the National Center, because we want patients to turn up. So it is still a challenge. The Department of Health is expecting us to find 50 patients by year one coming to the center. So far we have managed 21, and we're working really hard to hit the number 50, but that again is going to be quite challenging for us to do. And obviously, they are our policemen, so they police what we do in the National Centre, so from the patient's point of view, because we want this to be comfortable for the patients as well. So this is the big multidisciplinary team, and you can see this is clinical biochemistry, which is the department that I come from, and Professor Schenken is sitting there in the audience, and I've got other colleagues as well who can't be here today, so we are a big team supporting this endeavour. And besides that, you can see the whole lot of people there. Each of these people are in real terms involved in the service. It's not just names on the screen that you see. These are people who are real, and this is why Leslie, being in Liverpool, though, she knows that these people turn up and help manage our patients. And of course, we also have a close link with the National Centre, with the University of Liverpool, because ear biopsy. So we are doing ear biopsies which are being also studied in the University of Liverpool. So that link is also crucial to us. So, so this is the final sort of general boring slide, if you will, to say to you the latest number that has come to Liverpool in terms of National Alkaptonuria Centre is 21 patients so far. So we started in June, and the way we're doing this is we're trying to bring 5 patients, if possible, once a month during 1 week, because it is all about cost and efficiency in terms of making the most of funding, and we have 1 nurse per patient, and this is the kind of model that we followed so far. So we've seen 21 patients so far who have all been started on nitisinone.